Let's take a look at the warm-up. First question, what regulates the progression of the cell cycle from G2 phase to M phase? Well, that's the tumor suppressor p53. Next, the complexes of cyclin D plus CDK4 and cyclin E plus CDK2 assist in the progression of the cell cycle into which phase? Well, they assist in the progression of G1 to S phase. And the last question, the complexes of cyclin A and CDK2 and cyclin B and CDK1 assist in the progression of the cell cycle into which phase? These assist in the progression of the G2 phase to M phase. Now we're ready to get started with the lecture.
Hello everyone and welcome to our Step 1 video on drug side effects. Now Pharm can be a little dry because sometimes you just have to memorize a list of drugs. Now today we're going to try to make that a little less painful. We're going to group these drugs together by side effect. So we won't be going drug by drug, we'll be going side effect by side effect. Now we'll also have some clinical vignettes to start off each section so you can get an idea of how you might see these on your test, and we'll also throw in a few game shows to help with retention as well. So first let's start with cardiovascular side effects. And our first vignette is here. A 34-year-old man in the hospital is being treated for a severe methicillin-resistant Staph aureus osteomyelitis when he develops a full-body cutaneous flushing. So what's causing the flushing here? Well, when you hear MRSA, you almost always think about the drug vancomycin as the treatment. Now, this is red man syndrome. So remember, this isn't actually a drug allergy. You just have really just to slow down the infusion and pre-treat with antihistamines if you're going to restart that vancomycin. Now, what else can cause flushing? The other important one to remember is niacin. Niacin can cause a cutaneous flush. Adenosine, though not used quite as often as some of these other medications, is a very potent vasodilator as well, so it can cause cutaneous flushing as well. The dihydropyridine calcium channel blockers can also cause this by smooth muscle relaxation, but you don't see that quite so often. Next, we have coronary vasospasm, and that can be caused by cocaine. Along with cocaine, some of the other illicit drugs, amphetamines, methamphetamines, can cause coronary vasospasm. Your triptan drugs, like sumatriptan and ergotamines, can cause that coronary vasospasm. Those are treatments for migraine headaches. This doesn't happen very often, but we generally don't give triptans to patients with coronary artery disease or strokes either. Next, we have dilated cardiomyopathy. So this is potentially associated with doxorubicin and daunorubicin. So these are anti-cancer drugs. Next, we have torsades de pointe. So this is a twisting of the points, that sinusoidal wave pattern that you can see on your ECG. Drugs that prolong the QT interval are going to increase the risk of torsades. And so these include the class 3 antiarrhythmics, which are your potassium channel blockers. Also the class 1A antiarrhythmics, which are a category of your sodium channel blockers. Other drugs that prolong the QT interval include the macrolides. Think of haloperidol, which is an antipsychotic, chloroquine, which is an anti-malarial drug, and then the protease inhibitors for HIV. So let me go through those again. Potassium channel blockers, class 1A sodium channel blockers, macrolides, haloperidol, chloroquine, and the protease inhibitors. And what was the treatment of choice for torsades? That's going to be, you're going to push IV magnesium. Let's move on to hematology. So our vignette here, a 44-year-old woman is in the hospital for a deep venous thrombosis of her right lower leg. After several days of treatment, her platelet count drops to 30,000 per microliter. This one is going to be actually pretty easy. So what are you going to do the treatment generally? That thrombocytopenia can result from administration of heparin. And it actually has its own acronym, HIT, heparin-induced thrombocytopenia. What else can cause this? Cimetidine. So cimetidine is a H2 blocker. We don't use it that often anymore. And then another medication, again, for that thrombocytopenia. Now next we have agranulocytosis. In agranulocytosis, you're going to have the 3 C's. You got to think about clozapine, carbamazepine, and colchicine. You also have your antithyroid drugs, so propylthiouracil and methimazole. And then you also have dapsone. That's another one. So let's go through those again. The 3 C's, clozapine, carbamazepine, colchicine, the 2 antithyroid drugs, propylthiouracil and methimazole, and then the final drug is going to be dapsone. All these drugs are going to call agranulocytosis. Next, we have aplastic anemia. What can be as a result of that? It's going to be chloramphenicol, benzene, the NSAIDs, propylthiouracil, also known as PTU, methimazole is going to go in there as well. All are going to cause aplastic anemia. Next, we have gray baby syndrome. That's going to be caused by chloramphenicol. So this is a toxic accumulation of the toxic chloramphenicol metabolites. And this occurs in infants because that UDP glucuronol transferase enzyme is immature. And it's actually unable to metabolize that drug very well. So babies are going to vomit. They're going to have kind of an ashen gray color, hence the name. Limp muscles, hypotension, cyanosis, and cardiovascular collapse. Next, we have hemolysis in G6PD deficient patients. So we got to remember isoniazid, sulfonamides, primaquine, aspirin in very high dosages, ibuprofen, nitrofurantoin, that's a UTI drug, then also dapsone, favabeans, and naphthalene. So all of these drugs can cause hemolysis in a G6PD deficient patient. Next, we have thrombotic complications. This might seem a little vague, but what I want you to think of is oral contraceptive pills, especially if you have a patient who's a smoker and over the age of 35. They end up with a clot, think of OCPs. Okay, so let's see what we remember with our first game show. Remember, yell out the answer, especially if you're in the library. First one here, daunorubicin, doxorubicin. The answer is dilated cardiomyopathy. Next, macrolides, haloperidol, chloroquine, that's Torsades de Pointes. Next we have clozapine, carbamazepine, colchicine, a lot of C's there, that makes you think of agranulocytosis. An easy one, chloramphenicol, that's the only one that's going to cause gray baby syndrome. Next we have vancomycin and niacin, think of flushing. Next we have heparin and cimetidine, think of thrombocytopenia. Next we have respiratory. Our vignette here, a 56-year-old man presents with slowly worsening shortness of breath over the past several months. He denies cough, fever, or any other ill-like symptom. He has a past medical history of atrial fibrillation. The answer here is amiodarone. Amiodarone is often given to patients with AFib, and a very important side effect is pulmonary fibrosis. Now remember with amiodarone, you have to check your PFTs, your LFTs, and your TFTs. Now other medications that can cause pulmonary fibrosis include bleomycin and busulfane. Now those two are just anti-cancer drugs. Next one we have here is a cough. So the ones you want to think about here, ACE inhibitors. ACE inhibitors can cause a chronic cough, and the mediator of that is bradykinin. Remember, so bradykinin is in excess causing that cough. ARBs, the angiotensin receptor blockers, actually don't cause that increase in bradykinin, so they're often a substitute for ACE inhibitors when patients get that cough. Let's move on to GI. So here we have a 32-year-old woman presents with several days of worsening watery diarrhea and abdominal pain. About 2 to 3 weeks ago, the patient was ill with a sore throat for which she received treatment. What does she have? So this is probably pseudomembranous colitis, and what causes this? Well, any antibiotic can actually cause it, but the two that we get the most test questions are going to be clindamycin and then amoxicillin or ampicillin, very similar medications there. This patient likely got something like amoxicillin for strep throat. Next, we have hepatic necrosis. So this can be seen with excess halothane, excess acetaminophen, valproic acid, and then Amitina phalloides, which is a mushroom toxin. Next, we have just plain Jane hepatitis. A million things can irritate the liver, but the one I really want you to remember here is INH, isoniazid. Now let's move on to endocrine. A 66-year-old man presents with a progressive enlarging breast tissue. He has a past medical history of congestive heart failure. What's the drug? So this patient might be on something like spironolactone for the CHF, and though it occurs much less often, also digoxin has that potential to cause gynecomastia as well. Now other things that cause gynecomastia include estrogens, cimetidine, chronic alcohol use, ketoconazole, and then marijuana use as well. So there are a couple of decent mnemonics for these drugs that cause gynecomastia. Naturally, both of them are a little PG-13 and sexist. The old standard is the mnemonic, some drugs cause awesome knockers, and that's going to stand for spironolactone, digoxin, cimetidine, alcohol, specifically chronic alcohol use, and then that K is for ketoconazole. And then a student from Temple sent us another one that he came up with, stacked, S-T-A-C-K-E-E-D. Pretty similar list. So the S is for spironolactone, T for THC, so marijuana, again. A is for alcohol. C is for the H2 blocker cimetidine. K again for ketoconazole. The E is for estrogens, which should be pretty obvious that if a man is taking a bunch of estrogens, then that could lead to some breast development. And then D is for digoxin again. Moving on to hot flashes. So this can be caused by tamoxifen or clomiphene. So these are the SERMs, so the selective estrogen receptor modulators. Next, we have hypothyroidism. That can be caused by amiodarone. Remember, we're checking our TFTs with amiodarone. It can also be caused by lithium and sulfonamides. Okay, it's time for that game show number 2. Let's get going. So the first one here, amiodarone, bleomycin, busulfan. The answer is going to be pulmonary fibrosis. Next, we have spironolactone, estrogens, ketoconazole. That's going to be gynecomastia. Next, we have clindamycin, amoxicillin, ampicillin. Think of pseudomembranous colitis. Next, we have lithium, sulfonamides, amiodarone. That's going to be hypothyroidism. Next, we have halothane, excess acetaminophen, valproic acid. That's going to be hepatic necrosis. Let's go to our musculoskeletal section. Here's our vignette. A 50-year-old man presents with a swollen, red, and painful right first toe. This began spontaneously. He has a past medical history of diabetes, hypertension, and dyslipidemia. What meds are we thinking here? So, well, he's likely got gout, so you need to remember that the diuretics, like loop and even thiazide diuretics, can exacerbate gout. The one you may not have thought of for this patient is niacin. Maybe he has some low HDL, he might be taking niacin for that. It doesn't just cause flushing, it can actually worsen gout as well. Other drugs that include cyclosporin and pyrazinamide. Next, we have gingival hyperplasia. Now, classically, we think about phenytoin with this one, but also think about verapamil. Verapamil can also be associated with gingival hyperplasia. Next, we have osteoporosis, corticosteroids, and heparin. So you definitely want to monitor your patients with chronic rheumatologic diseases that are using those corticosteroids regularly. They're going to very quickly get osteoporosis. Next, we have photosensitivity. Think of sulfonamides, amiodarone, tetracycline. They can all cause a photosensitivity. Remember that there's a mnemonic that's been around forever, SAT for photo, to help you remember photosensitivity. Next, we have Stevens-Johnson syndrome. Remember, this includes seizure drugs, sulfonamides, and penicillins. Those are the general rules. And so your seizure drugs are going to include ethosuximide, carbamazepine, lamotrigine, phenytoin, phenobarbital. The one outlier that doesn't fit into this situation is allopurinol. That's another drug that can cause Stevens-Johnson syndrome. So remember, seizure drugs, sulfonamides, and penicillin. There's another mnemonic that you can use to kind of help you with this one, clappers, and that's with 3 Ps. So the C is carbamazepine, L lamotrigine, A is for allopurinol, P for phenytoin, P for phenobarbital, P for penicillin, and then E for ethosuximide. The R actually doesn't have a drug. It's just to remind you of rash. And then S is for sulfa drugs. Next, we have lupus-like syndrome or drug-induced lupus. So the mnemonic here is SHIP. So S is for sulfonamides, H is for hydralazine, I is for isoniazid, P is for procainamide, and then the other P is for phenytoin. Next, we have tendinitis, tendon rupture, and cartilage damage that can be associated with fluoroquinolone. So you might get a question about a runner who gets Achilles tendon tenderness while taking ciprofloxacin or maybe levofloxacin for something like a UTI or sinusitis or pneumonia. All right, so now let's move on to renal. Here's our vignette. A 27-year-old woman presents with fever, dysuria, and lower back pain. Her labs show a creatinine of 2.5, eosinophiliuria, and urine white cell casts. She has a past medical history of hypertension and chronic lower back pain. What do you think here? So it's not a slam dunk diagnosis, but this patient has interstitial nephritis. She may be taking NSAIDs for her chronic back pain, but also think about furosemide for her hypertension. Antibiotics are also a very common cause of interstitial nephritis. Next, we have diabetes insipidus. This can be caused by lithium and dimethylcycline. Now, what can we use to treat nephrogenic diabetes insipidus? Well, you can use hydrochlorothiazide. That's a very commonly used one. Amiloride is another one that you can use first line. Next, we have Fanconi syndrome. So this is a proximal tubular defect, and if the proximal tubules are not working, then you're going to spill all kinds of stuff into your urine that you should be reabsorbing. So this can be associated with expired tetracycline. It can also be associated with heavy metal exposure as well as Wilson's disease. Next, we have hemorrhagic cystitis. So this is associated with cyclophosphamide and ifosfamide. Moving on to neuro, here's our vignette. A 58-year-old man presents with new onset tremors in his hands. He has a past medical history of diabetes, hypertension, and chronic nausea. This one is a little bit vague. So this patient might have gastroparesis due to that diabetes and getting that chronic nausea. And for that problem, we often use metoclopramide. And that's going to improve that gastric emptying. Now, metoclopramide can cause a Parkinson-like syndrome. Other drugs include things like the antipsychotics and then reserpine. Synchonism. So first, you gotta know what synchonism is. So synchonism is dizziness with headache, vision changes, and tinnitus. Again, so dizziness with headache, vision changes, and then tinnitus. That's going to be synchonism. And it can be caused by the cues. So quinidine, which is a class 1A antiarrhythmic, or quinine. So quinidine and quinine are causing synchonism. Next, we have seizures. So this can be associated with bupropion. So if you have someone that maybe you're going to put on bupropion for smoking cessation or maybe for depression, you need to make sure they don't have a history of seizures or a history of head injury that might actually induce seizures. Other drugs, imipenem with cilastatin, can also be associated with seizures. Isoniazid, and there's actually lots of other things with increasing seizures. Tramadol, which is a type of pain medication, can be associated with it. Metoclopramide can do it as well. And of course, withdrawal from benzodiazepines or alcohol, that can cause seizures as well. Next, we have tardive dyskinesia, associated primarily with the antipsychotics. You can also throw in there a metoclopramide as well. All right, it's time for that third game show. Let's get going. First one here, sulfonamides, amiodarone, tetracycline, that's going to be photosensitivity. Next, we have quinidine and quinine, that's going to be synchonism. Phenytoin and verapamil, think of gingival hyperplasia. Next, we have hydralazine, isoniazid, procainamide, think of lupus-like syndrome. Fluoroquinolones, you got to remember tendinitis. Allopurinol, seizure drugs, antibiotics, think of Stevens-Johnson syndrome. All right, and for our last group here, we have just some multi-organ type side effects. So the first one is the disulfiram-like reaction, and that's going to include drugs like metronidazole, certain cephalosporins, procarbazine, which is an anti-cancer alkylating agent, first-generation sulfonylureas, which we really don't use anymore, so you're not going to run into that very often, and then disulfiram itself. Next, we have drugs with nephrotoxicity and neurotoxicity. That's going to include the aminoglycosides, cisplatin, and then the polymyxins. And then drugs that are both nephrotoxic and ototoxic are going to include the aminoglycosides, vancomycin, loop diuretics, and then cisplatin. And then anticholinergic side effects. More specifically, you might want to refer to these as antimuscarinic side effects, but we call them anticholinergic all the time. There are lots of different drugs that can have these side effects. Remember, these effects will dry you up. Atropine is sort of the prototype. That's a prototype anticholinergic drug. But there are other drugs that have this side effect. Think of the TCAs, the tricyclic antidepressants. The H1 blockers like diphenhydramine have this side effect. Low potency neuroleptics like thyroidazine and chlorpromazine. So you really shouldn't give these drugs to patients that have delirium or dementia or any BPH or problems with urinating or with any ileus. All right, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through this together. First question, what medication causes cardiotoxicity and maybe bone marrow suppression? So think of those anti-cancer drugs for bone marrow suppression, and the ones that cause cardiotoxicity are doxorubicin and daunorubicin. Next, an African-American male that goes to Africa develops anemia after taking prophylactic medicine for primary disease prevention. What enzyme is this patient deficient in? So this is a G6PD deficiency. So what drugs cause hemolysis in that G6PD deficient patient? Remember, primaquine is one. The patient here most likely took primaquine, the malaria prophylaxis in this question, and the result of that taking of that medicine is going to be hemolysis. Next, 65-year-old male patient taking multiple medications presents with gynecomastia. Which meds could be responsible for this patient's gynecomastia? So the big ones that I see on test questions more often than not are going to be spironolactone and ketoconazole. But also remember the estrogens, cimetidine, chronic alcohol use, and marijuana. And don't forget those mnemonics: some drugs cause awesome knockers or stacked. Next, a patient presents with tinnitus, dizziness, headache, and GI distress. What drug is causing these symptoms? So this presentation is synchronism, remember, and so this is either quinine or quinidine. Next, what medications are known for causing drug-induced lupus? So remember that mnemonic SHIP, and SHIP is going to stand for the sulfonamides, hydralazine, isoniazid, procainamide, and phenytoin. So these are the drugs that cause that antihistone antibody drug-induced lupus. All right, guys, that brings us to the end of our Pharm lecture. I hope you learned something. I'll see you next time.